As Jean Marie mentioned, my topic tonight is to talk about chronic illness and the pathways model. Well, I've already mentioned collaboration, and this pathways model is something I've worked on in collaboration with Angelle McGrady, my co-author on the two books on the screen here. Angelle and I have been friends and colleagues for 30 years. She's has a master's in physiology, a PhD in biology. She is currently the Director of Medical Education in the Department of Psychiatry at the University of Toledo, and is also practices in sports psychology and sports physiology. Angelle and I did a book together in 2003 called Handbook of Mind-Body Medicine for Primary Care. And in that book already, we were interested in integrating self-care into the process of professional treatment. Since then, we've had many dialogues. Questions arise. A patient comes and benefits from acupuncture. A patient comes and benefits from hypnosis or biofeedback, or even conventional medication. Hopefully, we benefit the patient, but what happens afterwards? We know that many of the complaints that bring people to see either a physician or a behavioral health provider or a nutritionist are the product of lifestyle, chronic life stress, the relationship conditions of the person's life. So what's going to happen when they leave our offices and stop booking further appointments? And eventually we evolved many of our practices into what we call the pathways model, and that's what I'm going to spend the evening on, talking about this model. We brought out our first book, Pathways to Illness, Pathways to Health, in 2013 on this model, and this past summer brought out the second book focusing more on chronic illness, which will be the topic tonight. This model looks at the continuum of health and disease and the role of health risk behaviors and well behaviors in shaping the person's overall health. We're interested in addressing the individual wherever they are on the continuum between health and disease, and identifying current levels of health, insufficiency, deficiency, or disease. Most importantly, we want to treat the whole person, changing personal behaviors and lifestyle before we even begin the professional treatment. This is John Travis's illness wellness continuum. This is a familiar diagram which he brought out first in 1972. He's still carrying on health education in publications and lectures. And this continuum emphasizes that we can identify where the person is on this continuum, and treatment is important at every stage. If a person is at the stage of, let's say, on the left end of the continuum, they're facing death, they have a terminal condition, it's not treatable, we can still address awareness, education, and growth for the time that that person has remaining. Or if a person comes to us with symptoms and signs of an illness condition, and our intervention helps them to become neutral, or we might say generally healthy, we can still help them to further modify their behaviors, their lifestyle, so they can sustain that well-being for the future, building a higher level wellness. Our interest is never simply to help a person reach neutral, but rather to move as much as is possible toward that high-level wellness direction. In our model, we've identified 3 different levels in which we can actively engage the patient. Level 1 involves self-directed behavior, lifestyle changes, increasing the person's activity, enhancing their sleep, assisting them with self-guided nutritional changes. Level 1 interventions involve restoring basic biological rhythms. By the time a patient reaches me with a chronic condition, they're often sitting in a reclining chair much of their day, living on fast food or prepackaged meals from the grocery because they've got very little drive or energy left for conducting the activities of everyday life. We're interested in increasing physical activity, and at that level, we're not talking about adding a aerobic exercise class. We're talking about increasing the time on their feet, the time perhaps to walk around the block, self-guided dietary change initially simply to begin preparing their own food, which already is a step toward better nutrition, and then carrying on sleep hygiene changes that can be self-directed. Level 2 involves acquiring skills, coping skills, self-care skills, self-regulation skills, using educational resources and also using community-based supports. Examples of level 2 interventions would be for the patient to learn mindfulness skills, to draw on progressive muscle relaxation or autogenic training, or hatha yoga. There are many educational CDs. Increasingly, there are smartphone apps to guide these learning processes, learning new skills. And at least in my community, the community I have practiced in for over 30 years, there are an abundance of community-based classes, and people can learn and form relationships while they're learning yoga or learning mindfulness. Level 3 includes the use of professionally delivered evidence-based treatments. Examples of professional intervention include biofeedback, neurofeedback, hypnosis, psychotherapy, medical care, medication, acupuncture, spiritual counseling, nutritional counseling, and therapeutic massage. Pathways interventions might apply a single skill area across all 3 levels. For example, take the area of mindfulness. At level 1, we can encourage a patient to undertake simple mindful breathing after an in-office demonstration. At level 2, the person may undertake mindfulness training and mindfulness meditation using an educational CD from John Kabat-Zinn or a community-based class. At level 3, the patient may be referred for mindfulness-based stress reduction or mindfulness-based ACT, acceptance and commitment therapy, provided by a trained therapist. So at all 3 levels, they're undertaking forms of mindfulness, but at increasingly intense levels. The Pathways model works through a collaborative alliance for health. For many years, we've known the lifestyle changes that will benefit human health. We recognize, for example, that sedentary lifestyle is antithetical to health, and activity and movement are beneficial for well-being. We know that poor nutritional choices contribute to ill health and chronic conditions, and that improving nutrition, especially in a customized in the fashion of integrative and functional nutrition, will be beneficial. However, in spite of knowing the kinds of changes in lifestyle which will benefit patients' well-being, physicians have been recommending get more sleep, get some exercise, you've got to eat better for at least 30 or 40 years, and it hasn't happened. If anything, our lifestyle in the American society has worsened over that same time period. So we're very much interested in a coaching process where the patient and the counselor or wellness coach identify the patient's needs through a dialogal assessment of an assessment process. In the dialogue, the patient is assisted to identify options, but ultimately the patient sets the personal goals for change. Follow-through is optimal when the patient has a sense of autonomously setting their own goals. There's a huge literature on compliance with medication and compliance with medical directions, and that's a dismal literature showing that long-term follow-through on physician prescription of medications and medical directions for change behavior is very poor. But if you think about the word compliance, it means my complying with somebody else's directive. In the Pathways model, we really are interested in an alliance for health where I facilitate the patient setting the goal, knowing that if the patient doesn't set the goal, they will not have the drive and the motivation to pursue it. We're also interested in looking at the readiness for change and matching the level and type of intervention to the person's goals, their needs, their current readiness for change, and their current resources. This is James Prochaska's stages of change model. He identified that sometimes people are at a pre-contemplation stage. They're not motivated. They're not even thinking. Pre-contemplation means they're not even thinking about the possibility of change. Contemplation means they're open to information, but they're going to delay starting or doing anything with that information. They're not ready for action. Preparation and determination means the person is ready to adopt change. They're getting themselves ready and they're planning action. Action means they're carrying it out. Relapse is a constant risk because many of us make behavioral changes and then lose a momentum, relapse. So recovering from relapse and developing maintenance routines is terribly important in this change process. Level 1 interventions in the Pathways model include, for example, mindful breathing, learning effortless, mindful, diaphragmatic breathing. I can teach the skills of mindful breathing in about 10 minutes, demonstrate and breathe with the patient, and then give them a handout or a download of our session that we've just had and ask them to practice at home. Many patients also do better with an app such as Breathe to Relax, which is a breathing app. Nutrition and feeding behavior, we help people to make healthy nutritional choices and to eat with attention, mindfully. For sleep, we identify and target maladaptive sleep habits when the person is ready to set goals in that area, and restoring a healthy sleep cycle. Introducing sleep hygiene, which is a set of guidelines looking at the sleep environment and sleep habits as they impact on the quality of sleep. We're also interested in facilitating movement, walking short distances or simply moving with music. With nutrition, more broadly, we're interested in mindful eating, looking at eating as a source of energy, appreciating the colors and the appearance of food, savoring the pleasure of food and the comfort of food, and then seeking some basic education, and eventually a referral for functional nutritional assessment. Another level 1 intervention, soothing. We think of people rocking in a chair, grandmothers rocking in a chair, and it's a very soothing process when a person rocks themselves, or people hum to themselves, or pray, or quiet themselves, spend some time in quiet. All of these are self-soothing activities, and they may sound self-evident, but many of the patients who come to us overwhelmed with stress feel like they can't afford to take time for themselves for self-quieting because the demands of their deadlines are so great. And it's precisely when people are overwhelmed with stress that they most need soothing behaviors. It's also the time they're least likely to engage in them without some kind of coaching process. Level 2 interventions, I mentioned progressive relaxation. This is a skill set developed by Edmund Jacobson, physician and physiologist, in which the person practices tensing and relaxing each muscle group throughout the body and noticing the difference, the sensations, the difference between a tense muscle and a relaxed muscle. And with practice, the person gains muscle awareness and also muscle control. Exercise, we begin with something very simple, stretching, slow walking, gradually increase distance. We may increase the speed. Meditation, quite a variety of meditation practices can be mastered with educational CDs or community-based classes. And when patients tell me, I tried meditation once, I just can't do it, I come back to them because there are literally hundreds of different meditation strategies, and some of them work better than others for this particular individual. Mindfulness training today, interestingly, increasingly, the people I encounter have heard of mindfulness. They're vaguely interested and often curious to learn mindful skills. Mindfulness is a particular way of directing our attention, focusing on the present moment without judgment. And we introduce a pause. We invite people whenever they're feeling stressed to pause for a moment and simply become aware of themselves and everything they're experiencing in this moment. And it's been interesting to me, Angela is the person in our team who pushed pausing more than I did. Since she first began to encourage me, I've begun to use pausing with many patients and found how useful it can be when we simply introduce a moment of awareness in the course of the day. In the community, in most communities, we have access to yoga classes, Tai Chi, Qigong, aqua therapy, gentle yoga, meaning that it's for people who are physically challenged, patients with arthritis, patients with fibromyalgia, elderly patients who have motion impairments can benefit from gentle yoga, and many patients who can't tolerate land-based exercise can handle activity in a pool with aqua therapy. So again, level 3 interventions carried on by a therapist with the patient. We don't get, in our model, we don't get to the professional interventions until the patient's already carrying on some of the level 1 and 2 activities. All the way through the pathways model, we want to emphasize the availability of CAM therapies, complementary therapies, we would say today, but many people still think of them as CAM, complementary and alternative medicine therapies, such as acupuncture, acupressure, various forms of energy medicine, including Reiki, functional medicine, functional nutrition. I'm delighted to find more practitioners in West Michigan, where I live and where I have practiced in the past. Body workers, Feldenkrais practitioners, Hanna Somatics practitioners, and others. Therapeutic massage, homeopathy, and naturopathy. And finally, we recognize the human being is body, mind, and spirit. And when people are stricken with illness, it's very common that they will experience spiritual yearning, spiritual anguish, guilt, searching for meaning. And I often find that there comes a time in the course of work with a patient with chronic illness where at least some kind of spiritual intervention or spiritual practices are called for dramatically. In some cases, pastoral counseling or working with a spiritual guide. In other times, simply a weekend retreat, a healing prayer circle, or meditation. Moving on to a case study. Now, when my colleague Angela and I did this webinar for AAPB, Association for Applied Psychophysiology and Biofeedback, about 2 months ago, we talked for 90 minutes, so we gave several case studies. So it was hard for me to pick one, but I decided to pick one. This is a patient with a chronic condition of anxiety. And her words, and you'll understand where these words come from. I always think of her words when I think of her. Her words are, "My house is crashing down on me," which was rooted in her life history, her life story. The integrative approach here is that developed by Angela and I, and this case narrative actually serves as a chapter in the 2018 book, Integrative Pathways. We know that anxiety is normal. We all experience fearfulness, anxiousness as a normal dimension in our experience. In fact, we should become anxious during major life transitions or in threatening situations. These are healthy responses to threat. Anxiety is only called a disorder when it persists, usually more than 6 months in duration, and when it begins to impair our functioning in everyday life. The Diagnostic and Statistical Manual of the American Psychiatric Association, we're now in the 5th edition. That manual recognizes these anxiety disorders that you see on the screen, running from panic disorder to generalized anxiety disorder, social anxiety disorder, just a variety of conditions. Anxiety disorders are the most common mental disorder in the US and Europe. Approximately 40 million people in the US, or about 18% of the population, experience an anxiety disorder. If you look at how often in the course of a lifetime, about 28 to 33% of the population will experience onset of an anxiety disorder sometime in their lifetime. And these numbers are fairly consistent in the affluent countries of the developed world. Anxiety disorders are common everywhere, including the developing countries, but the data is pretty consistent in the more affluent countries. People with anxiety disorders utilize more medical visits, more lab services, they miss work, they cost money in workers' compensation and disability payments. The annual medical cost for anxiety disorders 6 years ago was $33 billion. Social cost much higher. Typically, anxiety disorders follow a chronic pattern, remitting and relapsing. They go away and they come back. The median age of onset is low, 11 years old. And there's a natural decrease in prevalence, fortunately, with older age. I'm going to just finish this slide and then move into the actual case study. There's pretty strong evidence that there is a strong heritability. For example, panic attacks happen five times more often in monozygotic than dizygotic twins. If somebody in your family has generalized anxiety disorder, the chances of someone else having it is about 30.1%. So that's quite high. Now I'm going to switch to a case narrative. Judy was a retired social worker when she presented for care, 71-year-old woman, wife of a retired dentist, and at the time that I made her acquaintance, her spouse was diagnosed with a debilitating Alzheimer's disease. She was the mother of 4 adult children, grandmother of 6. She experienced anxiety intermittently from college through the present. She completed several episodes of counseling for anxiety, and she was frustrated that she wasn't coping more effectively now. She said, as a former counselor, as a social worker, as somebody with lots of counseling, she shouldn't need help now. On the other hand, when you hear her story, you'll realize any human being can experience a recurrence of anxiety in spite of our skills. She grew up in a professional family with a physician mother and an attorney father who was an amateur cellist. She was gifted academically and musically and originally aspired to be a concert pianist. She attended a private liberal arts college and her faculty encouraged her in music. During her sophomore year, her father suddenly died of a heart attack. She flew home for the funeral. During that flight home, she suffered a panic attack when the plane went through some turbulence. She experienced intermittent panic in the weeks after her father's death, and yet she returned to school and completed her fall courses. At Christmas time, her mother asked her to leave the private school, and this private school meant so much for her, yet the family finances could no longer sustain the private school. She physically shook during that conversation and experienced the worst panic attack of her life, with rapid breathing, rapid heart rate, and a physical sense of the house crashing down on her body. The family physician steered her to a female psychotherapist who used cognitive behavioral therapy to help her manage the panic. She was so impressed with her psychologist's compassion and skill that she redirected her own career aspirations towards social work and counseling. She did earn a bachelor's degree in music, but she added sociology and psychology courses, then earned an MSW and joined a group practice. She married her husband, David, while he was in dental school. She suffered intermittent anxiety and worry throughout graduate school and the years of adulthood, worked again with a psychotherapist after one period of anxiety, and once again used cognitive strategies to manage her anxiety. She continued her social work until age 68. But then her spouse's occasional forgetfulness seemed to progress, finally with the diagnosis of Alzheimer's disorder. She closed her practice and dedicated herself more and more fully to caregiving for him. 2 weeks after her 71st birthday, she realized her husband was staring blankly at her and did not recognize her. She experienced her heart racing, felt terribly alone, and she felt herself back in the moments after her father's death. She felt as if the house was crashing down on her. As he deteriorated in coming months, her own panic became more frequent and more severe. Her physician referred her to mental health professionals who provided an integrative pathways model program for behavioral and lifestyle change. Assessment, she met the DSM-5 criteria for panic disorder with agoraphobia. She reported severe episodes at least twice a week of an overwhelming experience of anxiety with attacks persisting more than 6 months. Racing and pounding heartbeat, rapid and shallow breathing, facial flushing, profuse sweating, and cognitively fears of her life crashing in on her, of being alone in the world, and of dying. Increasingly, she stayed at home, avoided public places. She rationalized that David needed her at home as his caregiver, but she also admitted she was not leaving the house because she was afraid of having an anxiety attack in public. At evaluation, she scored 23 on a Beck Depression Inventory, which is moderate, but she scored in the severe range on the Beck Anxiety Inventory, severe for anxiety. A 10-minute sample of her heart rate variability at evaluation showed a respiration rate of 21 breaths per minute, which is in the hyperventilation range. And one of the statistics for heart rate variability for her was 39 for her standard deviation of the time period between heartbeats. And this is an indication of compromised heart rate variability and lowered overall resilience, physically and mentally less resilient, producing lowered heart rate variability. Now, her family history showed a genetic predisposition to anxiety. Her mother suffered lifelong anxiety disorder requiring long-term treatment and recurrent treatment. We also know that caregivers in general are at risk for life stress and emotional disorders. A 2015 study showed that 43 million Americans provide unpaid caregiving for a child or adult in any given year. Approximately 16.6% of adults in the US are in a caregiver role, and many of these people are 75 years or older. Older caregivers tend to receive less unpaid help than younger caregivers. Persons caring for a spouse or parent report more emotional stress, and about half of those caring for someone with a mental health or Alzheimer's problem end up experiencing emotional distress themselves. Judy was very excited about making lifestyle changes, yet after expressing her enthusiasm about a lifestyle-oriented treatment, she broke down in tears and said, "I can't do it. I just can't do it." Her experience was that it was so hard to leave her spouse alone in the house or even to go into the next room to do something for herself that she couldn't possibly make behavioral change goals on her own. After extended discussion involving us, Judy and her physician, she agreed to a trial of 2 afternoons of respite care for her spouse weekly, which would allow her some time to commence personal care. Level 1, she decided to begin with mindful breathing. This is a useful skill for managing anxiety symptoms. She recognized she was breathing shallowly and rapidly. This was part of her anxiety experience, and as I mentioned earlier, we saw hyperventilation even when she was sitting in our office not having a panic. She still was breathing at a rate that we would label as hyperventilation. So mindful breathing was her first level 1 activity. She practiced the mechanics in our office of breathing mindfully, pacing her breathing with her therapist. She monitored her breathing with one hand on her chest, one on her abdomen to follow the process of her breathing, learned to breathe in through the nostrils and out through pursed lips. She learned to breathe mindfully with full awareness and slowly, often assisted by a smartphone app, Breathing Zone, I also mentioned a second app which is available, Breathe to Relax, and there are actually many others. Her second level 1 goal was nutrition. She was very knowledgeable about meal planning, the use of fresh market ingredients, and the advantages of high fiber, low fat diet with garden vegetables and fruit. But under the stress of caregiving, she had slipped into a pattern of reliance on prepackaged meals with high sodium content. She was ashamed but wasn't sure how she could put more time into meal preparation with the extent of her caregiving demands. She set the goal to return to the farmer's market and resume preparing 2 to 4 healthy dinners each week. With the encouragement of her physician and her therapist, she also agreed to try the Senior Lunch Meals on Wheels program 3 days a week. The next area of goal setting at level 1 was sleep. Her anxiety about her husband's nocturnal wandering severely disrupted her sleep. She had found him wandering once 3 blocks from her home. Under our guidance, she purchased a motion sensor alarm for the hallway, and the electronic chime of that alarm served to awaken her whenever he moved outside the master bedroom area. She also committed to using her mindful breathing at bedtime to ease her sleep onset and to use it in the night when she needed to fall back to sleep after something awakened her. Progress at level 1, already just practicing breathing on her own at home with an app, she reported a calming and inward absorption each time she practiced the mindful breathing. By the 3-week point, she was able to breathe at 6 breaths a minute with her app for 20 to 30 minutes a day. In many cases, physical symptoms of anxiety moderated within 10 minutes of her beginning her mindful breathing, all the way from severe anxiety to mild anxiety. She also included her spouse in the breathing sessions, sitting quietly with him, breathing audibly so he could hear her, and stroking his arm with each breath. He didn't seem to understand or be able to follow her instructions, but he calmed and began to breathe somewhat in sync with her as she held him and did her own breathing. Nutritionally, the most successful part of her initial goals for nutrition was accepting the senior meals. She actually was so relieved to find pretty good nutrition in what was provided that she set up a 6-day meal delivery with a luncheon meal for herself when he was away in respite. She also supplemented the delivered meals with salads and fruit from the farmer's market. And the practice of respite care, her husband's being away 2 days a week, gave her some precious free time to look at recipes and resume cooking on her own. She actually regained 8 pounds in the 10 weeks that she spent on level 1, which was very positive for her. Sleep, the motion sensor greatly reduced her nighttime anxiety and enabled deeper sleep. Using mindful breathing aided sleep onset so that it didn't take as long to fall asleep. She also found that if she couldn't sleep, she could get up and play her keyboard with a headset so she wouldn't wake her husband, but she would play the keyboard for 20 minutes and then resume sleeping. Level 2, she liked the mindful breathing and wanted more in the mindfulness area. So she began to read Jon Kabat-Zinn's book, Full Catastrophe Living. She began listening to a guided mindfulness meditation CD from Jon Kabat-Zinn, which is on mindful awareness and mindful meditation. She also decided to keep an emotional journal. She had kept a journal in college years, and that was soothing to her. She decided to begin an emotional journal using a format that I often recommend from James Pennebaker. He's published much research on his interventions, but he has a workbook, Expressive Writing, Words That Heal. And this is a passage from that workbook. Over the next 4 days, write about your deepest emotions and thoughts, about the emotional upheaval that has been influencing your life the most. Really let go and explore and how the event and explore how it has affected you, and so on. She also asked for something spiritual. She reported troubling guilt feelings about sending her spouse away from the home for respite care. She was able to joke about her Lutheran background and Lutheran guilt, yet she did ruminate on the guilt and the sin of selfishness. She decided that one of her level 2 activities would be weekly pastoral sessions with her senior pastor. She respected him as a biblical scholar, but he also seemed to convey acceptance. So she set that as a goal. What was her progress in this new level 2 area? She did very well with the mindfulness goals. She set a mindfulness goal each morning about some situation she anticipated that she wanted to approach more mindfully. She began to meditate for the first time in her life on days when her spouse was in respite care. And the combination of mindful coping and frequent meditation increased her sense of calm in everyday life, even when he had a bad day. Journaling, initially the journaling stirred up a great deal of pain, but as she continued, she began to find greater awareness of parallels between the time in her life after her father died and the time since her husband's decline. Remembering her new beginnings and her new directions after the father's death emboldened her now. She began to use a phrase that she had frequently used as a therapist working with others. She used this first in the journal, and then she began to use it talking to herself and talking to me. And she would say, I have this one, I have it, meaning confidence and mastery. Pastoral care. The sessions were very intense, much expression of grief. She grieved her loss of her husband as a companion, expressed her sense of burden and duty. She read Psalms with the pastor, and the words of Psalm 88 stayed with her. I am overwhelmed with troubles, and my life draws near to death. I am counted among those who go down to the pit. I am like one without strength. I call to you, Lord, every day. I spread out my hands to you. So expressing herself in these Psalms, hearing her own experiences echoed in ancient texts was very helpful to her. The pastor encouraged her to use her new mindfulness skills to encounter her moments of grief and guilt. And she found herself accepting her sense of loss more fully, experiencing her guilt and regret with less judgment and more of a sense of peace and more acceptance. She had a setback. Her spouse fell. After 6 weeks of her being in level 2, he fell, fractured the right femur. Once he was given a pain medication, he experienced more confusion. Eventually, he had to be placed in restraints and transferred for extended care in a rehab setting. She continued her mindfulness exercises and journaling and paced breathing, but suspended her sessions for a time. After he was placed in an Alzheimer's unit, she expressed again that, quote, she had this, that is, that she was able to face and manage the transitions. She asked to move into a level 3 activity. Especially, she asked for the level 3 goals to include something with counseling to reach a deeper acceptance of losses. We started with heart rate variability biofeedback. Now, she'd already been doing mindful breathing, breathing with a breath pacer at about 6 breaths a minute, which is also a component within heart rate variability training. But she was interested in biofeedback. She'd heard about it. She was interested in heart rate variability, and we knew that it's one of the strongest psychophysiological interventions for anxiety. She spent a session watching a biofeedback display, a multiple line graph with breath and heart rate fluctuations, and learned to smooth her breathing, producing a smoothing in heart rate. She was guided to call to mind her grief, and she watched the disruption in her breathing and the disruption in her heart rate activity. And then she used slow-paced breathing to restore the smooth oscillations in the line graph. So she was beginning to call up her grief, call up her distress, and then master it herself by her own intervention. We did a resonance frequency assessment, which identifies that single breathing rate, which is optimal for this person. I can't say more about that today because of time. I'm going to go on to her goal of acceptance and commitment psychotherapy. She had read about various forms of psychotherapy. Remember, she is a social worker. She asked for a referral to an acceptance and commitment therapist because it would build on the base of mindfulness that she was already practicing. Patients in ACT learn to, quote, just notice, accept, and even embrace their moment-to-moment experiences, especially those that they've previously combated. She continued her meditation practice during her spouse's treatment, his rehabilitation, and long-term placement. And she experienced an image of a circle, first a geometric circle, and then a circular path. Now by the way, this is, I've jumped from level 3 to level 2 because the level 2 practice of meditation actually impacted on her psychotherapy. I should explain that. She had this image of a circle, and she eventually interpreted it to mean that her father's death had taken her away from her original dream of music, and now her husband's decline was calling her back to music. So this was an image of a circle, but it was a circle in the path of her life and her life activity. So she chose a final level 3 activity, which would be a music class, a master class in piano. She decided she actually was doing quite well with the more therapeutic mind-body kinds of activities, and music instruction really was calling to her. So she decided she would take 2 weeks away for a master class in Germany. The oldest daughter agreed to stay in the home and visit the father several times a week while she was away doing music. So what was her progress? She was able to produce smooth heart rate variability, and she reported that the effects of her heart rate variability training strengthened her management of anxiety, strengthened her management of negative emotion. She shifted her motto from I have this to bring it on, and she told us she was becoming the Dirty Harry of anxiety management. In ACT therapy, ACT therapy, she reported that she was now able to accept events as they unfolded, as well as accept her own thoughts, even when the thoughts were negative. She said she was experiencing her life in slow motion. She liked the ACT intervention so much that she decided to seek out additional AC training for herself professionally. The master class in piano was so positive that she actually extended her stay. The daughter stayed on in her home, in Judy's home, and Judy stayed on in Germany and participated in an improvisational music festival. When she returned from the piano class, she said, I'm done with treatment, but she agreed to participate in a final assessment. The markers, the psychological markers, were improved. Depression was down now in the mild depression range. Anxiety was also in the lowest range, minimal, normal range anxiety. Her final marker for heart rate variability was up in the next functional level from where she started, up at 88. And her breathing rate, she was breathing in everyday life at about 12 breaths a minute, and she was able to breathe at her ideal frequency during times of breathing practice at 7 breaths a minute. It turned out that 7 was the optimal level for her. She made a number of life decisions, partly during her time in Germany and partly after her return. She sold the family home, purchased a condominium near several girlfriends. She looked forward to walking away from the house that was crashing down on her. And she persuaded the rehab system where her husband was placed to take her on part-time as a medical social worker / music therapist. She wanted to blend breath training, meditation, and piano in group sessions and in patient rooms. She was not a certified music therapist, and she was aware of that, but she integrated music into her mind-body practices with the residents in the rehab setting and with some group therapy. She was excited to become an itinerant performer around the rehabilitation system. So a couple lessons I draw from this. Remember, anxiety disorders are chronic, they're relapsing, and they're remitting. They go away and they come back. We reassured her that it would be normal, that anxiety may occur again in the future, but that her self-care skills would benefit her again in the future during any recurrence. Her story is also a reminder that life transformation doesn't just happen with mental health interventions. Educational pursuits, volunteer service, expressive arts activities all impart powerful life transformative effects. Both her master piano class and her new volunteer work played vital roles in her renewal. So that's my presentation. I went a little longer than I intended, but I hope that this still leaves some time for discussion with the class, or with those who are present, the class and others.
Thank you so very much, Dean Moss. That was wonderful and truly represented the spectrum across our College of Integrative Medicine and Health Sciences and the university of all that you walked through with this case study. So that was very insightful for me. Questions from the audience?
I think everybody's on mute. Should they type their question, or are you going to unmute them?
I didn't mute anyone.
Oh, well, I don't see audio out there.
I have a question.
Okay, go ahead. Identify yourself and then ask the question.
My name is Caitlin. I have a question for you around the different levels and when is appropriate to use different levels, because in my personal experience in dealing with anxiety, it helped me quite a bit to kind of have more of a level 3 intervention to start, to kind of jumpstart things for myself. I find that external stimulus kind of made me more able to personally pursue things individually. And so I wanted to make sure it was clear, like, when it comes to the different levels, like, when is it appropriate in the pathway model to kind of blend things together, or like, yeah, does that make sense?
That's a very important question. And I'm going to answer it in a couple of different ways. First of all, Angela and I, as we practice this, we are maintaining contact ourselves in a kind of a combination of health coaching, wellness coaching, and supportive psychotherapy during the entire process. So the person is experiencing therapeutic presence with someone, whether it's a coach or whether it's a counselor, during the entire time that they're setting goals for self-directed change, that they're taking community-based classes. And yes, there are times when it's important to jump ahead. I had a patient who was referred to me with such severe PTSD that both he and his family were quite concerned about suicide because he was so despondent. So we actually began level 1 and level 3 at the same time. So obviously there's no answer that's right for everybody, but I have found it's worthwhile doing quite a bit of work on self-directed change and lifestyle change, levels 1 and 2, before we get into sophisticated, demanding forms of psychotherapy, hypnotic age regression, dynamic therapeutic exploration of trauma, even complex cognitive behavioral therapy. Patients who have learned to do mindful breathing are going to do much better with CBT, cognitive behavioral therapy anyway. They'll do better with dynamic psychotherapy. Anytime you're learning these kinds of self-care skills, you're going to be a better therapeutic candidate, and probably a better candidate for nutritional change. I mean, we know that you can identify the absolute correct dietary modification and the optimal nutritional supplement for a person. And if they're under enough stress, they're not going to metabolize and absorb what they're now taking in. So when we make level 1 and level 2 changes, we're actually making a better patient to be receptive to interventions at the level 3 level.
Awesome. Thank you so much.
Well, you're welcome.
Don, there's a question in the chat box.
Okay, let me read that one.
Actually, it was Lucinda's question. I think Lucinda was going to jump in there with the question.
Oh, I see. There's
she wrote just to me.
there's quite a few.
Dr. Moss, I was curious, what was the time frame of that case study? Total time frame?
At least, I'm counting up that she was in level 1 for 10 weeks. She was in level 2 probably for 8 to 10 weeks. So probably 20 weeks before she began the actual psychotherapy and heart rate variability biofeedback. So 30 weeks total. And the frequency of the visits, Lori Taylor's question, initially every 2 weeks, then every 4 weeks while she was doing a lot of self-directed and community-supported activities, and then weekly for heart rate variability biofeedback and weekly for ACT. So a lot of weeks go by, but the weeks or sessions of level 3 intervention may not be that many told. I've had patients who did no level 3 intervention because by the time they'd practiced mindful breathing, increase their activity, improve their nutrition, and improve their sleep, they didn't have any symptoms to work on with a professional. So in fact, I've had people where level 1 interventions, just breathing, eliminated the need for any further treatment.
Wonderful. Now, in your presentation, you mentioned the 3 levels. Did you actually show those levels to the client? And
Yes.
As a method for buy-in of here's your choices that start here, so they're fully aware of the track?
Yes. Yes. Yeah, I think that's important. I think, first of all, people don't realize sometimes the extent to which their life stress is contributing, and don't realize the extent to which their lifestyle is contributing. It's been surprising to me how one woman began to do mindfulness, taking a class with a local church during her level 2 activity. And she suddenly said, you know, this stuff is magic because everybody at work is more relaxed now that I'm doing mindfulness. Well, of course, she was probably the typhoid Hannah bringing stress into that hospital unit with her fellow nurses. And as she became mindful and quieting her own response to other people, they became quiet and more mindful in their response to her. So we really do transform the world around us with these kinds of interventions.
Right. I want to mention last night, Dr. Moss, of a presentation that Luann helped sponsor, and it mentioned a website, SOHL and self-care practice.
Yes,
and
yes, from Dr. Ruth Ann Russo.
Yes, thank you. And I can see as an assessment tool initially presenting that, going into your pathways model, and then using it as a post evaluation of the progress. I think that would probably be a wonderful integration of both of these tool sets. So thank you very much. Wonderful.
Yeah, this is a good week for webinars. I watched Ruth Ann's webinar also.
Yes, it was great. So I agree. Thank you very much.
You're welcome.
Don, there's another question in the chat box. This is from Dr. Weissman, Jessica Weissman. Is massage therapy ever incorporated into your interventions? How?
Well, first of all, I think massage therapy is a wonderful adjunctive treatment for many medical and psychological problems. For a time period, I had a certified massage therapist working in my office setting, which was a wonderful opportunity. We had a hard time, unfortunately, we had a hard time giving her enough business to justify her continuing to come into the clinic. But for example, I was doing a lot of work with post-traumatic stress disorder and dissociative disorders, and we frequently scheduled a massage therapy session. And at the end of the massage therapy session, the therapist would invite me in with her and with the patient to talk briefly, and then the patient would come to the psychotherapy session or hypnosis often. And they had already often experienced emergence or surfacing of a variety of memories and feelings during the course of the massage, which massage can do with people who have been traumatized. And they were able to utilize those experiences more freely because of the massage. They were able to work those experiences through in psychotherapy. But of course, massage is also valuable in many other respects, working with chronic pain, working with chronic illness. Most patients have muscular tension, muscular bracing, and massage therapists can address some of those patterns depending on their background and training. I mentioned body work earlier, and a number of the massage therapists that I've referred to combine general therapeutic massage with either somatics or Feldenkrais interventions. So their person is getting a really important intervention for their chronic condition. I hope that answers the question.
I believe it does, and some people have pointed out in the chat box that they believe yoga practices would also be beneficial with the complement to the mindfulness.
Yeah, yoga's, I would guess that 1/3 of my patients leave doing yoga because I believe it's one of the most effective long-term intervention strategies to enhance lifestyle and keep people working, because they have an ongoing support group, which is a lot cheaper than level 3 interventions with an acupuncturist, a biofeedback practitioner, or a physician.
There is a question from Shoshana, and please forgive me, it's a slight long one. My understanding is that you led this intervention wearing the hat of a clinical psychologist. Is that correct? Had you been wearing the hat of an integrative wellness coach, would this intervention have been notably different?
In our most recent book, we've really emphasized the role of coaching to a greater extent because, first of all, I have worked for years intermittently with health and wellness coaches or life coaches. So I do think that the Pathways model is very appropriate. Obviously, an integrative wellness coach isn't going to be able to do acceptance and commitment therapy, but everything else that I described in this case study could have been coordinated by an integrative wellness coach. We're, first of all, establishing an alliance for health with the patient, assessing their readiness for change, doing perhaps motivational interviewing until the patient is able to set their own goals, and then assisting them in identifying resources to pursue their goals. So I do think much of what I do falls into the coaching basket, but I also believe that a well-trained certified coach could conduct much of what I do in the Pathways model. And by the way, integrative, or rather coaches generally, life coaches, integrative wellness coaches, health coaches, are eligible for training and certification in both hypnosis and biofeedback, which are 2 mind-body interventions. This is only recently, the last couple of years, that Eric Wilmarth and I and others have persuaded the certification organizations to recognize master's educated certified coaches for certification in biofeedback and heart rate variability biofeedback, and also to be members of the Society for Clinical and Experimental Hypnosis and attend all of the society training in hypnosis.
Don, I just want to point out, which I find so interesting, is that for the nutrition standpoint, you offered to her a rather easy, accessible resolution, where sometimes within our field we look for the most complex solution, and recommending Meals on Wheels is a resource that it's something that within all of our scope, and sometimes the easier solutions are the ones we bypass we're looking at different options. So thank you for bringing that to my attention at least.
Well, as long as you comment on that, thank you, Jean Marie. A couple of things. First of all, the other very simple intervention, the Surgeon General made a statement earlier, I guess in 2018, that simply cooking one's own food would already bring people a large step toward improved nutrition. So I often focus cooking and preparing one's own food. And then at least 2 of the case studies in this book, the Integrative Pathways book from 2018, I actually made a referral for a functional medicine assessment, complete assessment. And in one case, it was, I don't know if it was the functional medicine recommendations or another intervention she did based on a girlfriend's advice, but the nutritional interventions were the strongest, seemed to be the strongest interventions, bringing about a relief in suffering, but also changes in her blood work. And this was a woman with lupus systemic erythematosus, and her blood levels were such that she wouldn't have been diagnosed with lupus. And she felt that the nutritional interventions were the ones that brought her there. And I didn't even, I sent her to that physician who did that evaluation, that nutritional evaluation. I sent her there for acupuncture, and he decided she was a nutrition case. So it wasn't my wisdom, it was good fortune that she got to that practitioner. He did an evaluation and assessment, and she showed a pretty strong recovery, at least for the time being. And lupus is another illness where there's a waxing and waning or relapsing and remitting pattern. So it's possible she'll show severe again in the future, but to my knowledge, she's gone at least 3 years now without a recurrence.
And that does speak to the benefit of knowing other practices and working with and referring clients to other areas of expertise, so we can work together with that person. And also, we're not going to solve their problems necessarily ourselves, but working integratively.
Very much so. I agree.
Other questions, comments?
Yeah. Hi, Don. This is Kari Allenhammer. And
hello, Kari. Good to hear your voice.
Yeah, it's been a long time since I've been on these calls. First, I just wanted to thank you for this presentation. I found it was very interesting, and the case study that you presented was very compelling. And now I see why you said that there was a lot of similarities between your pathways model and my theory. I'm interested in reading more in detail on your model. Where can I find your book?
Well, the books are available through Amazon. Part of being a professional is that we don't push our books, but I'll take you back to the page that shows them.
Okay. Oh, well, yeah. I'm not online. I'm actually just on my phone.
The 2013 book, which introduced the model, is called Pathways to Illness, Pathways to Health. And the 2018 book, which applies the model to chronic illness and brings in more spiritual and complementary therapies, is called Integrative Pathways.
Okay.
And they're both by Springer.
Okay.
Angela and I now have a new design for a 3-volume set. We're sending out the outline this week, so we'll see where that goes. But it will return to integrative medicine, lifestyle medicine, and mind-body interventions as well.
Yeah, I think this is great, especially with the level of detail that you have shared, that I'm sure is much more is available in the books, and just sort of the awareness of the diversity of needs amongst people, and being really responsive to their needs. I just found all of that just really interesting.
Well, thank you, Kari. Kari is a graduate of our program, and she presented her dissertation research at our RC, our residential conference, in an integrative medicine symposium. I don't remember when that was, but I remember it was excellent.
Yeah, just a few months ago, last fall.
August, okay.
Thank you for joining.
Thank you.
Other questions? Was it Aletha who jumped on for a second?
Yes. Hi, Dr. Moss. This is Aletha. How are you?
Very good. Thank you.
Coming from the veteran side of the world and being exposed to many members who are exposed to PTSD and anxiety, I discovered that a program that has been driven by Wounded Warrior and supported by Wounded Warrior for equine therapy. What are your thoughts on equine therapy and what it does for healing?
I've actually supervised two, one master's thesis and one doctoral dissertation on equine therapy. And my own grandson benefited from equine therapy. I think our turning to the animal world, both for companionship, but also for healing. Increasingly, many therapists use a therapy dog. Equine therapy builds on the horse's sensitivity to the human being's emotional state. I spent a week at Sierra Vista out in Arizona, which is an integrative psychiatric treatment facility primarily for adolescents and substance abuse as well. And I had the opportunity to interact with the therapeutic horses there. And it was just fascinating. Even those of us who were there as members of a professional organization, you could see the animal's response was so different from one to the next because of that intelligent sensitivity of the horse. So I'm strongly supportive of equine therapy. Interestingly, it's much broader than I thought it was. I thought it was a relatively small movement. And then I taught in China in 2010, and I encountered a number of equine therapists in China working with horses, and they talked about the roots of it in ancient Chinese understandings. So it's a powerful intervention. I wish we had more access. I know the professional organizations for equine therapists, IGALA, and I forget the others, but I know that they're very interested in certifying good equine therapists. Anything else more specifically you want to hear or discuss about equine therapy other than
what level would you consider that for treatment? I guess what would you consider that a level 2 treatment or?
Well, you know, whenever you use categories, they're somewhat artificial. You could easily use that as a level 3 professional intervention as one therapy among others. But I think you could also say it's a community support and a person could go out and participate in equine therapy at the level 2 level, and then that would help prepare them for their professional treatment, whatever that's going to be. So I would say it's between level 2 and level 3, depending on how it's used.
Thank you. That was very good. And I appreciate your lecture. It was very well done. Thank you.
Well, you're welcome. My pleasure tonight.
Anyone else have questions, comments?
Well, thank you very much, Jean Marie, for setting this up and hosting this and recording it.
I think that goes in reverse. Thank you, Don, very much. This was very, very, very good for me to sit and listen to, and I think for all those in attendance. And I appreciate the attendees for taking the time to come as well. This has been recorded. We'll share it. And Don, I think many of us look forward to reading your books. So,
well, thank you.
Thank you.
People who write books always want them to get read, at least by a few.
Okay, well, good night, everyone.
Good night.
Thank you.
Thanks so much.
Bye, everyone. Thank you.
Hi, Celine. I heard Celine.
Hi.